everyone. Just to let you know again that the session is being recorded. Today, my name is Timothy Shaku, and I will be facilitating the session from now till hopefully late in the evening, around 6. The module we will be covering today is research-informed practice. We will sort of be tilting towards the healthy aging part. I'm not, I guess it's such a big cohort. I'm expecting about 100 or so or less. So just to give a quick rundown of the themes, I'm not sure how much people are too familiar with it. So in the themes, there is a chat function, which probably most of us know. By all means, use the chat function if you have any question, if you don't want to disrupt, because sometimes when presenter is presenting, it probably be you have a question in your mind and you don't want to let go. You can drop the question or you write it down on a pen. So the chat function, and just going to type in as an example, hello, good morning. And if you want to make contribution as well, you can use the chat function as well to make all your contributions. Apart from the chat functions, it might be that your colleagues or during the conversation, there is something that really excites you and you want to express, you can do that. There is an icon. So on the top of the bar of the screen of your screen, there are different icons. One is if you want to clap, by all means, you are more than welcome to clap. The second bit, if you want to, there are different emojis basically to express yourself. Then the third one is the same bit, some function that maybe I will encourage you also to use, apart from the dropping a question in the chat box, which some of them I probably will miss. I will encourage you also to consider the raising your hand function. Okay, there is a raising your hand function that you can do. And at some point, we will be doing some possibly group activity. So if you put in a group activity, there is a breakout rooms that it will, and when you go into your breakout room, I will highly encourage you to on your mic to contribute to the conversation, and where possible also on your camera. I'm aware that sometimes using the video tool, it will have an effect on the bandwidth of your or the internet bandwidth, and it also will possibly add to the how much data you consume. So yes, that's fine if your internet bit is shaky, but I would say consider without on your camera during your group session, but during your group session, kindly unmute yourself and you can have a conversation with your colleagues. Because we are such a large cohort, you can unmute yourself only when you want to make contributions. I will kindly ask that we mute ourselves all through so that to minimize the echo and the volume. And yes, by all means, if you have question at any point, please do feel free to chat. Before I carry on, just to sort of have a quick feel of the distribution of people in the class and where we are, I would like us to start by using the chat function. Can you put in your name? Just put in hello or good morning, whichever, your name and the state you are joining us from. So 3 things. Put in your greeting. Okay. name, and state you are joining us from. Okay, we'll be more than happy to welcome you. Okay. Like I said earlier, this session is facilitated by the Gombe State Branch of the Nigerian Society of Physio, and it's part of one of the 3 series of CPD they organized. If Abdulbagi is, I guess Abdulbagi is here, or any of the executives of the Gombe State Branch, please keep an eye on the chat function, and if there is anything, please bring it to my attention. Can I confirm that you guys can hear me quite clearly?
Yes, you are quite audible.
All right, brilliant. Thank you.
Yes, sir.
All right, thank you. We all know technology and internet, sometimes it can have its own mind. While we are thinking something differently, they will, it will fail us. So if by all means, and I believe we are fully aware, if by all means you dropped out of the call to try to join, absolutely fine. And if there is any break in transmission, we will keep in contact and we'll communicate to you on how best to proceed. I hope we have a very nice session. Amongst all the places you can be, you choose to be with me this Friday morning. So thank you. What we will be doing today is the outline. We'll be looking at, we'll have probably an overview of healthy aging, what it means, both globally and bring it back home in the Nigerian context. We'll look at frails and frailty to increase our awareness. We will, oh yeah, so there is something in between. Well, I will talk about it maybe at the end of my outline. And then so in the morning, in summary, in the morning, if you look at the outline that Abagi sent to you earlier, it's going to be a fluid one, but just to give you a guide of where we will be. But the whole idea is in the morning, we will have an introductory concept of healthy aging, specifically focusing on falls and frailty. And in the afternoon, we will look at research for clinical impact, where we introduced hopefully simplified the research framework, or the research that we'll be looking at, research in broad terms, but we'll try to be as specific as possible because we can't finish everything. So research in specific terms. And then there will be sort of activity for you guys to do. And then we'll look at what's the next step for you. So if you stayed in the session, and hope you can stay awake, let's see who is staying awake. Drink coffee, do exercise, do whatever you need to stay awake for almost 6 or 9 hours. At some point, there will be an activity for you guys. I will put in a challenge, I will say. There will be a challenge for every participant here. If you are able to, because probably more than one person will be able to meet up with the challenge. If whoever is the first person to be able to do the challenge fully, I will liaise with the NSP Gombe State chapter. Whoever we finally win the prize, he will have a full refund of their CPD fees for today. So whatever you paid will be returned to you by the NSP Gombe State chapter. Okay. So I'm not sure how much you're familiar. So there is what we call a Mentimeter. Mentimeter is an interactive platform that allows us to sort of engage. So I put in this first question. When you hear healthy aging, what is the first word that comes to your mind? So all you need to do is, if you, I appreciate some of you may be using your phones, so it might not be possible. If you are using your phones, you can, okay, some people are putting in the chat box, that's fine. So you can put it in the chat box, or you can scan the QR code if you are using a different device, or you can join the Mentimeter. So all you need to do is to go to Google and type Mentimeter, menti.com, and then you use the code showing on your screen, and then you will see the question about when you hear healthy aging, what does it really mean? I will give probably 45 seconds to 1 minute for you to do this activity. So just scan the code or scan the QR code or use the Mentimeter code. When you hear healthy aging, what comes to your mind? Okay. Yeah, I think people find it convenient to use the chat function, which is absolutely fine. Thank you. You can see a good distribution. Okay. Thank you, Naima. Thank you, Abdul Hamid. Okay. Yeah, hopefully you think about it. And so I guess we start from before the healthy aging, just to give us a definition of okay, staying from disease, free from disease. Okay, staying from free from disease. That's an intrinsic concept. We'll look at that. So let's start from the concept of there is aging and then there is healthy aging. Okay, uh, aging, we all know it's an inevitable process. All of us are on that road. All of us. Is an inevitable continuous process that affects us at different stages, at different times of our lives. So it's natural and it's progressive. However, there are three components if we look at from the concept of aging itself. There are three components that formed the aging. Okay, one is there is the biological aspect, there is the psychological aspect, and then there is the social aspect. The biological aspect, when you look at that in that angle, we're looking at maybe the most common ones that we can relate with. We're looking at the physical changes in our body. So that's the biological aspect. Any derangement from our normal physiological function. What does it look like? Example is as we grow old, there is reduced cell regeneration. Okay. Can I ask, please, let's try to mute ourselves. Okay, let me see if I can. Yep. Thank you. So as we grow old, there is reduced cell regeneration, decreased muscle mass. Our body becomes slower. So when we are younger, I believe most of us will probably have the ability of our body to repair itself is faster as we are in our midlife and things like that. But as we grow old, it's just like a brand new car. It functions very well. But as we grow old, the system starts to wind up, in summary. And so there is a lot of changes in the function. That's physical. And this is where you see the wrinkles on your face. You see the gray hair, the weak bones, and the reduced immunity. That is natural part of aging. Then there is the psychological aspect, which affects our mental and cognitive functioning. I believe some of us have come across our parents who can't remember what we told them yesterday. This, especially the very elderly ones, these are all part of aging, where your memory and your ability to learn starts dwindling down. And to a certain extent, there is a bit of reduced emotional regulation. And I've had in some quarters, of course, when we hear the word that like the elderly, you start to feel like they are becoming like children or something like that. But that's the emotional bit that they start to lose as time passes. And with the memory, it's just the slowiness of the information process. The last bit is at different stage of your life, the social changes. We all as you will retire, people will retire, and once you retire, the social network you have, you no longer have that. So there is that changes in relationship, although it's really appreciated, but it's also part of that aging process. There is that change in social interactions. The places you go, you probably won't be able to go. Your roles, your relationships, all changes. So this formed key part of aging. Okay. However, apart from aging, we have what we call healthy aging. Okay. So for healthy aging, it's about sorry, I think I'll probably go back. Not sure if you guys does it. Sorry guys, I think my slide just I keep on so we're gonna come back soon. Just gonna stop, just canceled and restart my, I'm not sure if you can still see my slide. Can you still see my slides?
It's visible.
Yes, we can see it. Yes, we are seeing
Yes, we
it.
can see it.
Okay. Not sure why, but okay, let me see. Okay, yeah. Oh, don't start from the beginning. Okay, start from the beginning. Yeah, so all right. So I think where we are. All right. Yeah. Ooh. Yeah. So for healthy aging, I think this is where we are. So for healthy aging, it's about maintaining that functional ability. So the WHO defines healthy aging as a process of developing that functional ability. So it's not only developing the functional ability, it's about also maintaining that functional ability so that will enable our. Okay, so I think somebody is trying to take back the presentation. Okay, okay. Synchronize to live view.
Excuse sir.
Yeah.
I think you should take control of the slide because you leave it just like that. Anybody can control the slide. That's why.
Yeah.
There is one place you should take control of the slide so that you can only move it to the next or previous slide. Thank you.
Okay. Can you let me see. These settings take control of the slide. Sorry, guy. I think somebody is trying to participation. Recording transcript. I think probably we'll have to dig through it. I would keep on doing. Hopefully we don't have the techie in the rooms that try to take away my slides. Anyway, So let's see where we are going to start or take control. Yeah, that's it. I've seen it. Thank you. Good. Brilliant. Thank you. Whoever makes that contribution. So, the healthy aging, who the WHO talks about the healthy aging is about the process of developing that functional ability and maintaining it. Okay, so two things: taking the function of functional ability and maintaining it. That's healthy aging. That functional ability, it's influenced by two factors. Is the combination of our intrinsic capacity. And when we are talking about intrinsic capacity, we are talking about around our physical functioning that we talked about earlier that affects normal healthy aging, physical and mental or biological functioning. And then the environment, we are talking about things that we influence that physical functioning, things that influence that physical function. It is a dynamic process and it adapts, it changes. Healthy aging is a dynamic process, it changes over time. But earlier on, I think, is it Abdul Mahid, if I remember, or somebody, when I asked about healthy aging, what comes to mind? Somebody talked about maybe staying free from disease or so. But I guess healthy aging, by definition, is not necessarily about staying free from disease in its sense. It's about your ability to continue to carry on your normal functioning irrespective of your situation. I think we have somebody should mute their mic. Yeah, mute all. Yeah. Okay. So it's not only about staying free from disease. It's about us functioning as much as we can. So let's take, for example, if we have an adult who exercises regularly and eats well, that person can maintain a good intrinsic capacity. So what we talked about, good intrinsic capacity, your muscle strength, good intrinsic capacity, you're able to do your day-to-day activity, your balance, compared to, so somebody who eats well, maintain exercise regularly, and can have a good intrinsic capacity. So the physiological or physical functioning that we all know about will be very sound compared to somebody who is sedentary. Okay. So that's one part on the intrinsic capacity. However, an older adult with reduced mobility, so the person may have comorbidities, may have other health conditions, his intrinsic capacity might be compromised, can still live independently if their home has some modification. So thinking about the environment. So it's not only about free from disease or injury, but think about the environment. Even if you have other comorbidities, which I think in reality, rarely can we see in our society now. Of course, we pray and God that should continue to heal or make us great and things like that. But we know most of our elderly ones have other comorbidities around them. So even with the comorbidities, how we modify their environment makes a difference on how we can define the concept of healthy aging or how an individual can be able to live sort of healthy. So in summary, and thanks for the contribution earlier, healthy aging, it's not only about free from disease, it's our ability or the ability of an elderly person or to be able to maintain their functional ability to practically enjoy their life and well-being, okay? To do the things they can do with or without modification. And why it matters? Well, starting looking at it globally, where I am now, I'm in the UK, I believe it's a massive, big problem. In fact, there is a massive investment in not only elderly care, but falls prevention. And the reason is because maybe we will see the West, they have a growing a health aging problem, a lot of the elderly populations, and the impact it has on the particularly the healthcare system is massive. So, for example, an elderly person living at home had a fall. That particular person here in this country, the health system is being paid for by the government, everything will be picked up, go to the hospital, stay in the hospital, may or may not have surgery. Falls is one of the main causes of hip replacement or hip surgery here. And that is also free on the health system. So that is a lot of money. After the treatment, the person might need to go to a center before they go back home. That is a lot of money. So one, it has a massive health impact on the health system, but also it has cost implication for the whole societies. That's why they consider it as a big problem. And I believe in most Western societies, they consider prevention as the key to still salvaging the situation. So if they invest in preventing the falls at the first place, then there will be no need for additional person to come into the hospital and occupy the bed space, or there will be no need for the government to spend resources on trying to either do the surgery or rehabilitate the individual, which is much, much, much cost effective. In Nigeria, I would say, based on my knowledge and sort of the literature, it's still early. Although the government, the society is still evolving in terms of what we prioritize and things like that. But Africa is one is we although we have the young population, but at some point we will grow old. So the aging population, there is a demographic shift. There is a demographic shift of people going to that elderly population number. It's something that it's an opportunity for us as healthcare professional physios in particular to look at how we can step in that gap, try to see how we can help our people within the society, within the community on how we can improve their health and well-being through what we will probably be considering later in the stage. But the presentation also, we are also human in our own journey of life. I have put in on my slides that I want to also see you live well in your old age. So I guess it's the question of doctor, take your own medicine with this healthy aging concept. So it's about us thinking also as a person, we benefit from it, but also our clients or patients, they also benefit from it. But I know there are factors that will influence this sort of healthy aging concept, particularly focused on Nigeria. Now, I give examples of here. Maybe they have the money to spend on other bits. They have, but in Nigeria, we have the socio-economic factors where there is the weak, so the healthcare access is not there. So I'm not sure how much of falls prevention activity is going. I'm not sure how much of community-based falls prevention activity is going because we more focus on the tertiary provision of care. We more focus on the reactive system of care. But this is a factor that hope maybe will affect the way our elderly population aged. One, healthy aging is a process. It doesn't happen when you are ill, when you go to the hospital. It happens even before you fall sick. It's that investment in your life process. And there is also the cultural aspects of it. Okay, there is also the cultural aspect of it. Here although it's not cut across the whole system, but sometimes we feel like the elderly people, there are different things. There are traditional beliefs where we feel the elderly people, there is that spiritual myth around the elderly people, and we sort of despise them, and we're not interested in investing in their health, basically. But also that's on that one aspect. On the other aspects is when we grow old, we feel like, oh, I have worked really hard. So it's well, which is good, but it's time for me to rest and relax. And all the non-healthy behaviors or things that will not that we tend to shy away from them. For example, I will know that in my community, certainly back home in Nigeria, is you more unlikely to find the elderly sitting down for probably from morning till evening than finding a community of elders just walking around, going for a walking group just to invest in their health, and it affects their lifestyle. So there is that economic aspect, there is that cultural aspect, which we have to take into account in terms of that bit. So, but healthy aging, it's a lifelong process. While we are talking about elderly population, but healthy aging is a lifelong process. It's not just about older adulthood. It's a decisions we make right from our childhood, I would say. Okay, everything we do now, and we're doing now, is an investment for the future. Actually, they said that Friday that will be good. It's from the Wednesday that you will see it. So we don't have to wait till our grandparents start to complain that they are falling or they have a fracture or things like that. We can invest in their physical health. We can invest in their cognitive functioning. We can invest in other bits. And in and we think about how they will retire gracefully. But as we are investing now, even if at the older age, and that's where we come in as physios, interventions can reduce and improve the quality of life. So let's say everything, we've missed the early age, we've missed the midlife and everything at that elderly age, intervention or investment can reduce and improve that particular quality of life. Just a quick summary of in terms of what's our role in the healthy aging. I'm not going into the detail, but just to highlight what's our role in the healthy aging. One of the main things that we can easily do without raising a finger, he says, is promoting physical activity. One of the things we can easily do without raising a finger is promoting physical activity. Here in the in UK, for example, which is my first point on the PowerPoint, is there is what they called MECC. MECC, it stands for making every contact count. MECC, it starts from, and you can Google it and find more about it. This is an investment that the country as a whole invests in promoting physical activity. So when we are talking about a national policy of intervening in people's lives, so we're talking about public health policy. This is an example of a public health policy of promoting physical activity. And what is MKCC? We all know that there is strong evidence that physical activity have great benefits, but one of the things for healthy aging is for everybody really, but for all healthy aging, it's also very important. So making every contact count is an approach that where every single healthcare professional, when they come in contact with the patient or client or service users, different terminologies, they should consider promoting physical activity amongst their patient. So that can be the question of, from your conversation, how much they move. Okay. If somebody talks about, for example, they are not moving at all, you can encourage them to be maybe taking a few steps every day, or exercise every day, or referring them to community centers because they exist. So it's about every healthcare professional to increase our awareness that when you come across a client, patient, service users, you should consider promoting their physical activity. And why is that? In our entire life, the reason is in our entire life, we are more likely to come across, to go to hospitals, we are more likely to come across healthcare professionals. So it is being realized that despite the multiple opportunities, people come to the healthcare professionals. So maybe they will come, oh, I have a back pain. And all you need to do, sometimes all we think about is relieving the pain, or I guess my practice in Nigeria is about maybe putting the IRR and doing the massage or applying the cream, and then off the person goes. And we don't think about any other thing else. But it's actually an opportunity to add an intervention that will, like that, just by encouraging them to be physically active in a safe way. So that's the whole approach of making every contact count. And we all know that regular physical activity is the most effective behavioral strategy for promoting healthy aging. You can carry it out. From all my presentation earlier till now, I guess one of the things that I will highlight is healthy aging. I would say it is a process, and that process, it's the most important thing is behavior. Okay? Is the habit you will develop, or we will develop in terms of, or encourage our patients to develop, to invest in their life forever. It's not a pill that you will take and then it's gone. No, it's an investment and it carries on forever. And physical activity, it's one of those things that it will not sort of be a burden. It's just a prompt. There are different ways to promote it. And maybe just to ask, just to ask, and please, by all means, you can mute yourself or you can share it on the chat box. Can somebody remind us of what is the WHO, World Health Organization, physical activity and sedentary behavior recommendation? Anybody? You can unmute yourself or you can put it in the chat box. Anybody can remind us? What is the WHO, World Global, not necessarily, the global recommendation for physical activity and sedentary behavior? We are the health, because I guess there is high expectation from us. If we are promoting it, we should know what we are promoting. Anybody? Anybody wants to remind us? What is the World Health Organization physical activity and sedentary behavior recommendation? You can unmute your mic to share your, or you can put it in the chat box. Okay, thank you, Esther. 150 minutes per week. Okay. Thank you so much, Esther. But I think, can we add a bit of more detail? So yes, 150 minutes per week of what? So there are maybe somebody, yes, carry on.
Minutes of exercise per week.
Okay. It doesn't have to be you, Esther. Anybody can contribute. 150 minutes of exercise. So exercise is a very broad. Yes, somebody is contributing. Yes.
Okay, I think it should be 150 minutes of moderate exercises in a week.
Okay. Thank you, eBay. 150. So eBay has taken it a bit further, which is true. 150 minutes of moderate exercises per week, but still, it's a bit broad. Can somebody add a bit more detail to it? So moderate exercise, yes, of what? So there are different, when you are exercising,
Aerobic.
yes, who is, yes, Yes, thank you, Ahmed. Thank you, whoever contributed. So 150 minutes of aerobic exercises, okay, per week. So aerobic means there is you are exercising your cardiovascular function basically. So you're looking at the intensity of it. So that is one part, okay, but let's talk about that one part. 150 minutes of spread across. So the 150 minutes can be across 4 days, across 5 days, but in a whole week, just spend 1 hour 30 minutes doing some exercise. Thank you, Naima. So in a whole week, think of spending 150 minutes of aerobic intensity exercises per week. Now, with the moderate bit, it's about whereby you are walking. Imagine yourself walking and you sort of, you are walking fast, brisk walking, and then you are finding difficulty to walk and talk basically, but you can still do it. Or alternatively, they talked about 75 minutes of vigorous intensity exercises. The sedentary part of that is we limit the amount of the time we spend in sitting. Now, apart from the fact that we can walk in terms of exercises, there is also a danger whereby you can accumulate or get the 150 minutes of exercises. However, you will sit down for 6 hours at a go, or you will sit down for a long period of time. Now, new research evidence within the last decade or so have suggested that it's not enough for you to do the exercises. You are also at risk of all the things that if you sit down for a long period of time, basically. So that's being sedentary. So being sedentary means sitting down for long. So you need to be breaking or limit the amount of time you sit for a long period of time. But in addition to the aerobic intensity exercises, there are also other advice in terms of trying to work on our balance, flexibility in a week. And I will encourage you, that's not the focus of today's session. As healthcare professionals, I will encourage you, the activities I will ask us to do. If I have my way, I will put it as one of the, what do you call it? Post activity before you get your certificate. But anyway, that's just by the way. Go and find out and probably have it on your fingertips. What is the physical activity and sedentary behavior recommendation, which I think most of you do anyway, but just to remind ourselves. For older adults, there is that push for need to include balance and strengthening in 3 or more days per week, okay? Because it affects their ability to continue their normal day-to-day function. It exposes us to the risk of falls. Another bit is preventing falls, and how we do that is the first point above. We can prevent falls by, one of them is promoting physical activity, but I believe also there is that part of education where we educate, where we advocate, and where we do things. There are multiple roles of physios. I'm not going to exhaust and go into that. That's not also the main. We're just trying to establish some premises as we go along. Okay? And then managing frailty and sarcopenia, loss in muscle mass. Okay? Managing frailty and sarcopenia. We'll touch briefly later on frailty. So thank you. So that's me again. So I have another, you can either scan the code or join it or put it in the chat box. You can scan the code or join or put it in the chat box. So the question is, what are the socio-cultural beliefs about aging and activity that you are aware of in your community? So looking at our environment, what are those things that you think might affect healthy aging? I can give you an example of mine. I think, well, not a really example. I think most of us might resonate with it. An example is, we all know that our elderly people are more likely to sit down for a long period of time. If anything that comes in, my daughter, go and get me this. My son, go and get me this. And they, oh, I want to take care of my parents and spoil them. And we encouraged a highly sedentary life. And to a certain extent, because of there is that mind of when we are trying to encourage somebody to get and less sedentary, and that can be just in between, you can go and get your cup of water, in between I can go and get your food. It might sound a bit in code disrespectful. So that's another bit. So I want you to think, and can you please add it on the chat box or use the scan code? What are those socio-cultural beliefs that you think influence aging and activity that you are aware of within your community? Okay, sorry, my mic was muted. So I hope I'm not muted for long. So what I'm saying is that, can you put it in the chat box or scan the code? What are those social cultural beliefs that you think that influence aging? The example I gave is, I said, in which you guys will resonate with in our society. I am fully aware that sometimes there is that concept, oh, my daughter, go and get me this. Oh, my son, go and get me this. And the person that is sending us or to do these things is seated for 2, 3, 4 hours, not knowing that sitting down for a long period of time takes away that benefits of them to break their physical activity. And if they have to use the opportunity to stand up and go to the kitchen and get the water or things like that, it will have make a difference in their life. So sometimes it's not only about running to go and do the exercise, it's just the belief that we have to respect elders, allow them to rest. Thank you so much. I think whilst I'm talking, there is excellent ideas presented in the chat box. And if you've not seen it, I think you should go and have a look at the chat box. So, so let's have a quick look at what is written in the chat box. So Chibuze mentioned about poor diet, okay, excessive carbohydrate, okay, yes, influence aging, yes. Everybody, Chibuze, you can't take away from that. Everybody loves their swallow. You cannot take away that taste of it anyway. Yes, but that's true. Chibuze. Level of education, Zainab, yes. Level of education, yes. And it's sad because with the level of education, it's at that stage whereby we struggle, our health system, we struggle with our own physical health. We don't know that there are lifestyle changes that we can make that can make a difference. Okay. Oh yes, absolutely, Mohammed. Yunusa believes that elders need to rest at the end of their life. I think this is one of the main things. They'll say, oh, we've worked really hard. Oh yes. But funny enough, some of those activity, physical activity, it makes you refreshing. It makes you come alive. It improves your mental function. So thank you for the contribution. Keep them coming. And for those that are just joining us, I can see we have a very large number now. We have clocked the 100 mark. Okay. Can we give ourselves a round of applause? We have closed the 100 mark. The session started about 1 hour ago, but we have closed the 100 mark. That's good. Let's give ourselves a round of applause. Well done. For those that are joining us now, not to put you on the spotlight, you've missed something in the beginning. In our outline, there is something I talked about. I said that at some point throughout today, there will be a challenge. If whoever is the first person to respond to the challenge, I will refund their full CPD fees for today. So there will be a challenge. It might be, I didn't know what it will be. So I guess we all need to be vigilant. There will be a challenge. It might be questions that you respond to, but whoever is the first person and I will let you know when that has been, whatever, well, when it comes, you will be aware of it. They will have a refund. I know it doesn't cost 3,500 now. It's I guess the cost of living is too low, but you can invest it in the next CPD ready. Okay. So going to the next bit, still in the question, thank you for those that have put in the contribution. What is the one thing that your community could do better to support healthy aging? So we've talked about all those things that influence. What is that thing that you think could do better to support healthy aging? Can you still put it in the chat box, please? Thank you. Can you put it in the chat box? What do you think is that one thing that you could do to support healthy aging? Use the chat box, please, and add your contribution. Okay, thank you, Esther. Okay, Abdul Mahadid, I agree with you, is the key. Yeah, education. Yeah, yeah. I believe the NSP are here. Is one of the creating more awareness. Yeah, Kalu, yes, absolutely. It's one of the things that I think they could do. They could facilitate as well. Awareness. People believe in awareness a lot. Mubarak mentioned about balanced nutrition. Okay. Yeah, there is a lot of awareness. Morning and evening, 30 minutes per session. If you want, okay. I like that contribution from yours. Morning and evening, 30 minutes. No stress, just 30 minutes gisting with your friends. So instead of having a conversation in sitting down, you can decide to do all the gossips in the evening by walking around your streets. Okay. But then the question of whether it's a safe neighborhood to do that. Yes, Semudara. So senior clubs. Yes, Semudara. I agree with what you said. I think let me go back to what Semudara mentioned. She talked, or he mentioned. Semudara mentioned about having elder cycles. I think that's an excellent idea, or clubs where they can come together for recreational activities or game. So here in the UK, there are a lot of charities and government-funded establishments where there are community centers. Some of them you will have physios. Some of them there are no physios. It's all about the group of people coming together where they encourage this activity. For example, they can have a working group. They can go and do some chair exercises, some sitting exercises. And as a healthcare professional, when I was working in one of the practices in the community, so I worked in the community before. What I do is when I finish seeing a patient, so patient can come to you as a physio, and then once I finish seeing the patient, when I'm discharging them in court or referring them, I can ask them, I can find those community facilities and then encourage them to join or to continue explore using those community facilities. Sometimes even before discharging them, I will go into those community facilities with them just to facilitate them reintegration, especially if they have a particular health need that needs to be taken into account. Or even gym, I will go into them just to get into that habit before we discharge. So thank you so much. I think you guys are brilliant. We can have that bit. Absolutely brilliant. And thank you. I think Suleiman just put in a bit of statistics. Yes, spouses are the major support of elderly and the majority seek medical help. Yes. So family, spouses, family. So it's about the local context in our local society. So there is a need for free health insurance coverage for the elderly here in Gombe. Absolutely yes. Free healthcare coverage. Absolutely yes. And it will make a difference. Absolutely yes. Education and counseling. Yes. These are brilliant ideas, and some of them are cost effective, really. It won't cost creating centers to practice safe exercises. Yes. Naima, I will challenge you. Sometimes this these some of the ideas. For example, these health centers, health club, working group, safe exercises, we can do that easily. We have all the associations going on in our communities. I know there is all these women development associations, there is all these women fellowship, there is all these groups in our society. Do you know that all we need to do sometimes is going in, talking to them and meeting the leaders and asking them to just have 10 to 15 minutes of maybe just moving around the cycle, or maybe just marching on the sports, something that just to make them physically active before they start their session. And we can do it after their sessions. Okay. So thank you. There are a lot of activities. I will encourage you guys. Some of those ideas need a bit of further exploration. You can take that as a challenge and look into exploring that. I know I've been talking. Is there a question so far? Is there a question so far? Or anybody wants to? I think you guys have been adding a very brilliant contribution in the chat box. Okay. So healthy aging is a lifelong process and not something that we only start in the elderly. And that is why I talked about us also benefiting from it. Okay. It's a lifelong process and not only starting from the elderly. However, whatever stage we find ourselves, there is still that opportunity of shaping it. That it is affected by the choices we make, the environments, and the interventions that is being delivered. And it's never too late to intervene. But our key role as physios, I guess, it's that particular bit of intervention. But we can't wait for it to be intervened. We can do the preventative aspect. That's where the public health comes in. So thank you. Falls is one of the key main problems for the elderly. Okay. And it's an event where the person comes to rest inadvertently without you planning. You just come to a state of rest at a lower ground. There are three key things in the definition of falls. The unintentionality of it. So inadvertently, you find yourself in a state of rest at a lower ground. So it can be on the floor, or it can be from a high place you are to a bit lower place. You don't have to go all the way down to the floor for you to have fallen when there is that change in the level at which you are. And it is as a result of, not as a result of major stroke incidents such as stroke when you're having a heart attack or stroke, but you just, for example, have a trip and you couldn't recover, and then that's it. Now, we as individuals, this falls or activity, it happens, we as individuals in our day-to-day life, we interact with our environment when doing our day-to-day activities. And we talked about healthy aging earlier on. We talked about healthy aging is the ability of the person to develop and maintain their functional ability to enable them to enjoy their well-being, basically. And in that doing so, that is when these falls happen. Okay. And it tends to happen when there is a mismatch, between the physiological functioning, the individual physiological functioning. Earlier on, those that joined us, we talked about the individual physiological functioning is the derangement in our biological system. Okay. The weakness of the muscles, our system is the derangement in the physiological system, which is more likely in the elderly. Okay. But it's not only about the derangement in the physiological system that we talked about earlier on, because we said you can still have derangement and still function very well. It's also the environmental requirements that you are performing those tasks. Okay, so the environment also have put a demand on you. So it's the environmental requirements that you are performing those tasks that also influences how we fall. So yes, elderly are more at risk of falls. And in my picture, if you look at the picture on your left-hand side, you can see I strike the elderly bit because everybody can fall. I believe all of us have at some point, maybe, but most of us have fallen. Okay. So maybe the environmental requirements challenges us. Yes, we may have physiological function, but the environmental requirement follows us. And then the last part is there is also the individual behavior. So three things. When there is a mismatch between the individual, that is the physiological functioning, and then the environmental requirements and our behaviors, all of these things, either one of them or combination of one or two or more can affect our ability to not to follow. Okay. So we will take turns and look at them in turn. Okay. They will take turns and look at each one of them. Okay. So when we are walking, and I would like you to help me with this. So we are looking at a physiological function. When we talked about physiological function, we said we are looking at our body systems, basically. So what do we need in our body system, looking at the physiological functioning? And you can put it in the chat box. You can unmute yourself and say it. What do we need to have in place in terms of physiological functioning to help us prevent falls? Let me give you an example. Let's say vision. Okay, we need our vision, and why? Because it gives us that spatial orientation of our surroundings, and it provides us feedback. Okay, so when you're walking, so think of it as when you're going to climb the stairs. Okay, your eyes will inform you, and you prepare proactively that there is a stairs ahead, and it gives the information to your brain system, and the amount of force it's pushed through to the muscles, so to say. So that's that feedback mechanism, and you are able to regulate to pick up your leg to that just about height that you can put it on the stairs. Okay, so it gives the feedback, and then everything kicks in. So we need our vision for the environment. It helps to detect hazards and uneven places. We need that. However, in the elderly, that can be compromised. Okay, but again, we'll talk about that in terms of our assessment later on. Okay. Thank you so much. I can see a lot of examples in the chat box. Muscles integrity, yes. Muscle strength, yes. Efficient vestibular system, yes. Good economics in workplace at home. Okay, yep. Okay, thank you. Yes. So one is vision. We need our what we call proprioception. So within our joint, in our muscles. So these are sensory receptors. So proprioception or proprioceptors. Proprioceptors are the sensory receptors in our muscles, muscle spindles, and joints. So, for example, Golgi tendons. Yes, orientation in time, place, and person. Absolutely, yes. Somebody have put there. So they allowed us to sense the environment and to adjust appropriately. And sometimes, even without us seeing or without our visual input, the proprioceptive input help us to regulate our environment and help us to prevent falls. But sometimes, of course, if there are decline in age or neuropathy, sometimes the sensory aspect is compromised. Then there is that reaction time. So sometimes you can trips, but your ability to recover as quickly as possible, that is the reaction time. So is your neuromuscular speeds and the central system processing. And in the elderly population, the reason why they can't recover, one of the reasons rather, one they can't recover is their inability to react quickly. Okay? because they have that slow reaction time. The system is winding down, so that corrective actions is not there for them. We have the muscle strength, which I think you guys have talked about, and I think you guys are expert on it. I'm not going to talk much about it as well. We have the cardiovascular and respiratory capacity. The cardiovascular is about the endurance. It prevents fatigue during movement. Our patients tend to, once you reach towards the end, when somebody is exhausted, the high likelihood of, based on my experience as well as the research, for them to fall is greater. Okay, is greater. And then those poor capacity can cause a bit of dizziness. And somebody to make sure about balance and coordination. So it's that integration of those systems, because balance is a multi-system activity. So bringing all those multi-system activity to integrate them and to maintain our upright and stability. So yes, when we walk, when we are talking about, we need that to prevent falls. And then we talked about pathology. Pathologically, this can be affected, or physiologically due to natural process of aging, this can be affected, okay, which we talked about earlier on when we start the conversation today. However, the good news is many of these functions that we highlighted can be improved, and that is where our role comes in as physios. We can identify whatever is defective based on the evidence, and we can help remedy the situation. But sometimes it's not possible to rehabilitate or remedy the situation. It might be the question of compensatory approach. Somebody with a poor balance, there is no, sometimes as the natural, it's not possible to get the balance all back to where they were before. Is the question of giving them a walking stick. So that's an example. So it's the question of compensatory approach. Or somebody with poor vision is the question of finding glasses for them. Depth perception is the question of finding glasses for them. The next bit is the environmental context. Okay. The next bit is the environmental context. Now, there are two scenarios that I have on the board. And I want you to tell me what's the difference. So have a look at the two scenarios I have on the board. Can you help me and let me know what's the difference? You can unmute yourself or you can put it in the chat box. What's the difference?
Hello.
Yes. Hi. Yeah, carry on. Isa, yes.
Yes. In regard to this, I can say for the young adult or athlete, so despite having the strong muscle physiologically fit, but due to some obstacles, so might alter, maybe might challenge his step. But for the elderly one, so when there's an impaired physiological function, as what we have suggested in the chat box, like muscle imbalance, maybe loss of proprioception. So even if, so in that aspect, even
Okay, I think Isa, your network, we lost you a bit, but you are making an excellent contribution. If you can hear me, I would like you to finish your thoughts when you are back. Okay, but eBay, do you want to finish it up or do you have a different thought?
Okay, from this thing, good morning.
Morning.
From what I read there, probably as a young adult,
Yeah.
there are some things that some environment will find ourselves in that will not necessarily lead us to fall.
Okay.
But if he's an adult, let's say because of as a young person, you can even move around in maybe a dim lighted house or anything,
Yeah.
or places that is jam packed. You will not even fall. You may not fall. But for
Yeah.
another adult that already has physiological impaired physiological functions and all,
Yeah.
then in the same situation as you,
Yeah.
it will not be the same. It will eventually lead to fall.
Absolutely, yes. Thank you so much. Yeah, that's another way to look at it. Thank you. I think Isa is back. Isa, do you want to finish your thoughts? And then we continue. Okay, Abdul Mami has hands up, but I want to hear you finish your line of thought, Isa, if you don't mind, if you still, because I think you're right on track.
Okay. Okay then. In regard to that,
Yeah.
elderly individual,
Yeah.
by considering they have poor muscle integrity and
Yeah.
loss of proprioception,
Yeah.
and even some neurological aspect like some of their let's say vestibular system.
Yeah.
So having all this kind of physiological uh, impaired physiological function might predispose them to
Yeah.
fall, even with a little support like a cane. Sometimes
Yeah.
even with tripod cane, they might even get fall unless they have given Zima's frame. So which is that there's a quite different. So for the younger ones, actually, it's only an obstacle. Maybe on our way, they might just like sleep, or maybe like fall in the maybe in the hole or pothole, something like that. But an elderly, even in a flat surface, uh,
Yeah.
well structured with rock, and it's not slippery, they might get fall due to imbalance. So that's it,
Okay.
my own contribution. Yes.
All right. Thank you. Thank you so much. Uh, I'm not sure. I think there was a hand up, but the person brings it down. So if that's fine, I think that two contributions are brilliant. I agree with both Ibe and Isa. Coincidentally, they are both eyes. Uh, so what they said is true. The first scenario is despite the strong internal systems. Okay, so young adult or an athlete who was well trained, they have high physiological system. So despite the strong physiological system, the complexity or unpredictability of environment can overwhelm the body's systems or body's ability to respond quickly enough, and it can lead to fall. So it's all about the responsibility of the body quickly enough to the challenging environment. And no matter how, if the body cannot respond quickly enough, sometimes it can be due to, which is the last part of the things we will consider, our behavior, which we don't assess the behavior appropriately, which is the third leg of the conversation. We can find ourselves in this situation, or sometimes maybe unpredictable. And this is the example. The next one is the part B, which EB I think mentioned quite clearly, succinctly, is even in a safe environment, and Isa as well, even in a safe environment, predictable safe environment, the body may not be able to maintain stability due to the limitations in that bit. So that's the difference between the two. So the environment have an influence, but also we know that they do interact. So the person's ability to perform the task depends on both the internal physiological systems as well as the environment, the external environment at which they interact. And like just a side note, so when somebody comes to your clinic or when they've fallen, it's not enough for you to just think, which we'll talk about in our false assessment. It's not enough for you to think, oh, they have weak muscles that's why they have fallen. You need to work on that field more. It could be, yes, you can work on the weak muscles, particularly for the elderly, but it could be their main problem is the environment, which I think, in my experience, maybe things have changed. We probably don't appreciate environmental context more, that influences individuals' health or health function. So the third leg is the behavior. Okay, the behavioral context. So we have two people. Okay, both of them person B. But the person A has fewer risks, fewer falls. Yes, Suleiman. So we have two people. They have high physiological risks. So they have compromised physiological function. So all of them are on the same level. They have compromised physiological function. But the first person, which is A, has fewer falls. The second person, which is B, has more falls. Why is that in terms of the context of the behavior? Anybody wants to explain the two difference for us? Yes, Isa.
Hello. In terms of this, I can say since they all have same status, but just in regard to activities that they expose themselves that lead to fall. So the first person, the person A, uh, he walks on a flat surface and
Okay.
with a how will I put it, with a stick. Why the person B walk in a challenging area, actually climbing stairs, with as well as without any supportive device like cane. So considering they all have same status, physiological status, then let me put in this aspect, but the person B is not exposing himself into a challenging area and also taking some precautionary measures like using supportive device, while the other person just exposing himself to a challenging environment, likewise is not taking a precautionary measure of using assistive device. So this is it.
I think the key word here is predisposed himself, precautionary measures, predispose himself. And by repeating those two things, you are talking about behavior. So it's about the behavior of an individual. The behavior of an individual influence. So irrespective of our physiological systems, irrespective of the environment at which we function, the behavior of an individual can compromise those two, and that can predispose us to fall. Before I continue, I think Esther, your hand is up, or is it just a legacy hand? Behavior. Thank you, Lily. Yeah, it's about, yes, Esther.
Yes, so it was. It's actually said a lot of things. It was just on the point that I don't know they both have the same limitations and their environments might almost be similar. But the difference in person is that he has made some modifications based on his limitation, which enables him to still move freely in his environment without any risk of fall, which is what we see in the cane and in the avoiding risky situations. While person B, with the same limitation as person A, he hasn't made the necessary modification, which is getting a walking a bit more conscious, and hence why there's more falls, even though they both have the same limitations.
Thank you. And one of our role as physios, it's about safe behaviors and risk awareness. Our role is not only to treat the patient, it's about to educate the patient and increases their awareness to fall. You can take it because there is this thing called common sense, but actually, as professionals, I don't think we always have to take that approach that everything is common sense. Our role and responsibility include educating our patient that, look, you have a compromised physiological system, and yes, we are working towards that, but before we do that, I think we need to take safety precautionary measures, or maybe we are not going to get that compromised physiological system back. So what we need to do is we need to find a compensatory strategies on how you can be able to safely function in your environment, because it's better safe than sorry, they say. So, but looking at the picture now, then come the question of behavior. It is possible for you as a physio to educate, the risk assess and educate and advise the patient. Let's look at the two scenarios. You see the both two patients. You assess the both two patients at a high risk of physiological falls and whatever it is, the system compromised. Yes, you feel like they have a compromised system, and at this stage is the question of in their functioning, you advise them to use a walking stick. And secondly, maybe if they're going to use a stairs, they should use a rails, or you ask them to avoid using the stairs. Person A goes ahead and obey, or well, not obey, follows, stick to your advice, use a walking stick, and avoid risky situations. For person B, ignores it and then finds himself in a very difficult situation. So what happens is sometimes our patient falls or exposes the risk of falls, not because of those two prior factors what we discovered, but it's possibly also because of the behavior. We all are different. We have different personalities. And sometimes in our clinics, when we come, irrespective of our advice, sometimes that's where our clinical reasoning comes in. There are tendencies where we can identify patients at high risk, whereby you know that they are impulsive, they are more likely to be to expose themselves to risks more, and then you have to take necessary advice or repeated instruction or whatever, or family to intervene to support and things like that. So that's the behavioral context, and there are influencing factors that influence key influence on the behavior. We have the cognitive functioning, the behavioral context. So sometimes it might be the person, and especially the elderly people, they might have problem with their judgment in safe decision making. It's not that they are ignoring you, but they have problem with safe decision making, or maybe the memory. Just because you say it today, that doesn't mean they remember it tomorrow. So it's about those repeated instruction. They might have lack of awareness and knowing when to ask for help, or availability of support or system around. And we talked about the implication for practice as physios. These are the things that we need to consider in our practice. Thank you so much. And the next bit is thank you so much for all the people contributing and everyone really listening and joining. But the next bit is, what do your patient tell you are the response that causes their fault, the reasons that causes their fault? I know we are practicing in different areas, which is fine. We are still on the pathway to talk about a bit more about research at some point, just laying the foundation. But as a physio, I believe at some point you might have come across patient falls or fallen. What is it that the reasons that cause their fault? If you asked, actually, what is it the reason that they say? You can put it in the chat box. Or Francisca, yes, you want to say? Yeah, Francisca, you can unmute.
Yeah, my patient told me that NEPA just took light.
Oh,
and
wow.
that she feels she's used to the environment, so she continued moving. That's how she felt.
Okay. And just asking Francisca, what do you think based on what we discussed? Do you think what do you think contributed to our fall?
The place was not well lighted. She was not seeing well. Vision.
Okay, vision. Yeah. Okay, thank you. Thank you, Francisca. Yeah, it is possible the patient has compromised physiological system, like you mentioned, vision, and it is possible now, not possible. We know the fact when you talked about the NEPA took light, which is common, then obviously the environment is influenced. But also another bit is maybe this is just one option, one thing that happened, but it could be a behavior because the risk assessment, if NEPA took light, you might need to think whether you can be able to continue or not. Okay, so the behavior, or maybe because another patient might decide to not to continue working in this situation because it's highly risky for them to fall. But again, it's about a pattern. So the fact that it happened once, that doesn't mean they have a behavior of it also. Yeah. Thank you. Yeah, I can see a lot of contributions. Please keep them coming. Thank you on the chat box. So our conversation in today, this morning, is there are key three factors that influence false risks: the physiological system, the environment, and the behavior. It's important, and I think Francisca just gave us an excellent example, NEPA took light, which we can all resonate with. It is important we look at those things in as a whole and how they influence our patient. Because it has a devastating consequences. Okay, it has. Oops, somebody said they can't see the slides anymore. Can you see the slides, please? Can you still see the slide? And you confirm? Yep, you can see the
No,
slide.
I
Okay.
can't. No,
Okay.
I can't see the slide.
Can other people see the slide, please?
I can see it.
Okay, you can see it. Okay. It might be some
Me too.
lagging. Okay, brilliant. Thank you. So if you can't see it, it might be some lagging in your internet. I just changed the slide. So I just changed it to another slide. So maybe that's why. So it's uploading. I just changed to the next slide. Okay. I think for globally, and especially in the developed countries and here in the UK, when I started, I talked about the investment they have on health system and things like that. They understand the impact of falls. It is devastating, it's life-changing, it changes your life trajectory completely. So it's not only the cost it will cost the government, but the individual, it can change the slide completely. And that is, this quote here summarizes everything. It takes a child about 1 year or so to acquire independent movement, and 10 years to acquire independent mobility also. What an older person can lose everything in a day. That's devastating. So it has a big impact on our patient and client. And that's why I think it should be taken seriously. But also for ourselves as individuals, we are talking about education, education, education. We being the health professional, we can also take a leap from it as we go along our life trajectory to appreciate that falls can make a difference or a big impact in our lives. Falls and frailty, they are sort of intertwined. What do I mean by that? Frailty affects the individual's ability to respond to stressors. So think of the frail individuals. A frailty affects the individual ability to respond to stressors. So a small trip can result to falls. They are almost synonymous because one of the main consequences of frailty is falls. Looking at the picture here, so there are three scenarios. One is managing well. An individual that is not frail and is exposed to external stressor. And what I mean by that is it can be that you have an infection, or it can be you have a trip, just a small trip. Any minor injury or illness, the person can recover quickly and then bounce back, and then life continues. But an individual with mild frailty, exposed to external stressor, can recover, but sometimes it affects our ability to bounce back. But we can bounce back with support. You can have a temporary immobility. Physio can help you to get your independence back. Then the severe one is sometimes, really most of the times, when you are exposed to external stressors, the person become dependent, hospitalized, or go to care home, or probably they can't be able to bed bound, or they can't be able to get back on their feet. The more a frail is, I get this, the key message is the more a frail is, the less able they are able to recover from minor stressors. But I will refer us back to one of the first slides we talked about earlier today. We talked about healthy aging. This vicious cycle. So if somebody is frail or is at the risk of frail, there is more likelihood that they will be in that cycle of injury, disease, and everything. But we as health professionals, the healthy aging is about us trying to break that cycle. Okay, breaking the cycle through early intervention. Because a frail individual, which mostly happens in the elderly, and it is our basically our ability to maintain reserve. Frail individual mostly happen in the elderly, and we can risk assess in our community, in our society. We can develop whatever strategies where we can those that are frail. We know that their ability to respond to external stressor has been compromised. They're reserved. We talked about healthy individual is about developing that reserve. So their own reserve is not there, it's been reduced. We can work with them and improving those reserve even before they have those external stressors so that they can be able to bounce back. Frail individuals, so let's go back to our prior slide. It is possible to reverse these frailties early on, whereby the individual will not progress to a severe level of frailty. So from mild to moderate, you can work on the person so that they can continue to function. That's the concept of the healthy aging. But once the person is at the severe frailty, while they can still benefit from your intervention, but it's difficult at this stage to reverse it. And that's why it's sort of a lifelong investment. So there is a vicious cycle of falls and frailty where a frail individual is highly exposed to falls. Now it's just on time. I think we are really on time. 10:30, and I think it's time for us to take our eyes off the screen, to stand up, to stretch, to do whatever you do, to go to the loo, to grab some cup of water. So I take 5 of your minutes. So we're going to have a 15-minute break. So I'm going to ask us, we can take a break here. We come back by, so this is 10:35, 45. So 10:50, so 10 minutes to 11. Let's be back by 10 minutes to 11, please. 10 minutes to 11. By 10 minutes to 11, we're going to start immediately. Okay, so let's be back by 10 minutes to 11. Thank you. Okay. Welcome back. That's our time, 10:50. I guess people will be joining us as we go along. Just to make sure that I'm not the only one in the room, can you just drop me a message in the chat box to make sure that there are people before I crack on? So if you're here, yep, okay, brilliant. Yes, Isa is here. Okay, yep, thank you. Yep, okay, yep, brilliant. Thank you. Good. Okay, thank you. So at least there are a couple of people. Yep, thank you. So yeah, thank you. Brilliant. So we will continue. So false assessment. Okay, so false assessment. So how do we look at people who have fallen? What do we do about it? There is this flow chart. This is developed by the NICE. So the NICE is the National Institute of Clinical Excellence. It's a governing body. It's the organization here in the UK that is responsible for setting guidelines. Okay, guidelines for practice. So most of the public hospitals have to follow those guidelines unless if none exist, then they find the best available evidence or justify why not to follow guidelines. So the NICE have given this as a way of looking at patients with falls. So let's start from the beginning. Right on the top, that is the entry point. The blue, the one that is colored in blue. So the first one talks about, it's about the two entry point is about how you possibly can come across the patient, okay, patient with falls, how you can come across them. Earlier on, when we were talking, I think Francisca mentioned about her patient told her that the NEPA took light. So one is that we can come across patient that can present to our healthcare system. So the patient will come to our healthcare system that have falls or falls related injury. This type of patient, the evidence shows that they are more highly likely, 70% chance that the view is poor. Okay, I will try to get, thank you. Ooh, let's see. I will upload it on the WhatsApp so that we can have it, so that I will not just be talking. Let's see, I can quickly upload it now. Thank you for that feedback. Let's have a look. Or maybe let me put it on the chat box here, and I will try to upload it also. I think the participants WhatsApp, or maybe let's see if I put it here. Can somebody put it on the participant WhatsApp, please? Yeah, So hopefully you can open it and view it and download it and expand it. It's just a lot of information that I guess I can't, there's how much I can be able to. So yes, I've put it here. Can you put it on the WhatsApp? Those that people, somebody should transfer it please to the WhatsApp, or we can all use it also from here. Okay, so let's come back. So, okay, it's okay now, Al-Qasim. Okay, brilliant. So it's 70% of those with risks of falls, they are more likely to fall in the next year. They are more likely to fall one or more times in the next year. So when a patient presents with you, that bit is the question of, have they fallen within the past 12 months? This is false history. So that's one of the main point for assessment. So if you look at your sub note as a physiotherapy, so the sub note, we are talking about your subjective, objective assessment plan. So taking the history will fall under the subjective bit. So false history, within the last 12 months, one of the questions we asked, how many times have you fallen, or most false assessment template. And if they've fallen, they will tell you they fall, and then that's a yes. And then we assess the fall severity. So we're talking about I'm looking at the pathway on my right-hand side. So it will be also hopefully on your right-hand side. So I'm looking at the yes category. We assess the fall severity. And if they answered yes, look at the injury, they have an injury, they have fallen more than twice in a year. So one thing with falls is more than once in a year, so two or more. Then if they've fallen two or more, then we categorize them as high risks of falls. High risks of falls. And once they are in that category, then the goal is to develop a secondary prevention because they are fallers already. So it's to prevent them from having that frequent falling. Because like we said in the beginning, somebody who has fallen, they are more like 70% chance that they will fall again. So it's trying to prevent them without treatment. So secondary prevention and treatment. And it is recommended once they are at high risk of fall for us to consider what we call a multifactorial falls assessment. Okay, multifactorial falls assessment, which we'll talk about it. So looking at different aspects that contributes to fall. In our conversation earlier, we said that there are different aspects that contributes to fall. So you need to look into every single bit of those different aspects that contributes to fall. I will leave the last two parts. We will talk about it in my subsequent slide, the intervention. We're looking at assessment in this section. So those with high risks of fall, you look at different aspects, a comprehensive review of what contributes to their fall. The same patient that presents to our clinic, okay, if we assess them and it's a no, they have not fallen more than twice in a year, they are not frail. Frailty is another thing that we looked at. They've not lied down in the floor for a very long period of time, all those questions. Then if they said no, but it is recommended for us to look at their gait and balance. They talk about gait and balance impair. We look at their gait and balance, and we will look at those outcome measures also later on. So in the gait and balance, we look at their gait speed because it's a predictor of falls. The slower a person is walking, the high likelihood of them falling. For example, you can use the 10-meter walk test, which is used for what we call community ambulation, to assess the ability of an individual to be able to function in their community very well. Here they talked about anything less than or equal to 0.8 meter per second is at risk of falls. Or we look at time up and go test. Time up and go test. here the NICE guidelines, the guideline is the anything more than 15 seconds, it's at a high risk of falls. There are the risks of falls. And if we do the assessment and the outcome measure shows that there is a problem with it, is we categorize them as intermediate risks. And the goal is still secondary prevention and to improve on the risk factors, okay? To improve on the risk factors, secondary prevention and to improve on the risk factors. And I will skip the last parts for the intervention. But apart from our patient, which I think is typically that maybe you come across based on the experience, apart from our patient, it is possible for there is what we call opportunistic finding. Maybe it's less likely in Nigeria, but here sometimes there is that annual health risks visits. There is a maybe just by the way they sort of accidentally review your case notes. It's not that you've presented because of falls or falls related issues, but maybe you went in for a different issues and then it was picked in your records and then you are at risk of falls. That also, if you had a 30% chance of falling in the having another fall. So if it is an opportunistic finding, usually the question is the same question, history of falls, how many times have you fallen? Or sometimes they try to be sensitive. If you can ask the questions about frailty, for example, if the fall they've had they been lying down for a long period of time, just to determine where to go next. And if it is a no, then it goes straight to low risk. It's a no, it goes straight to low risk. However, the primary prevention, whereby, remember we talked about healthy aging, whereby they are encouraged, example, to continue to do physical activity, so that or to educate them about falls and fall prevention programs. So there are lots of falls prevention programs. Earlier on, some people talk about community centers, elderly cycles. So you can refer those here in this country, you can refer those patients to those fall prevention center where they don't have to fall before they prevent it. That's falls prevention. So before it happens, primary or secondary anyway. So we can refer them or we can encourage them in our context back home in Nigeria. We can refer them to we can encourage them to be active, to take an evening walk or to move around. And I will skip the last part for the intervention. The main thing is it's multifactorial assessment. One thing with falls, especially those with a high risk, it's encouraged for us to have multifactorial assessment, looking at every single bit of aspect that affects them. And we all agree that it's not one thing that contributes to fall. It can be one thing, yes, but there can be more than one thing. And it's important we look into that. So what I will ask is, what do you include or should we include in falls assessment? Okay? What do we include or should we include in falls assessment? So what are the things that you think we should include in falls assessment? I want us to make a bucket list of it. What should we include in falls assessment? Let's make a bucket list of it. Can we put it on the chat box? What should we include in falls assessment? Or you can unmute yourself if you prefer, and then you can share your thoughts. But I want you to help me. What should we or do you include in falls assessment? Okay, age of a patient. Okay, age of a patient. check their proprioceptive flexibility. Okay, thank you. So that's two. I think we can do more. So what should we? Yep. Okay. Balance, figure. Yep. Muscle power, memory. Okay. Outcome measure, time up and go test. Okay. Assess their gaze. That's interesting. Assess their gaze. Whoever the process do you want to expand on when you say gaze? You can type it in the chat box. What the yes, so maybe you're referring to vision. Assess balance. Okay. Physical abnormalities. Okay, that's a very big one. Okay, PCV, gait analysis. Okay, gait analysis. Yeah, just by the way, also maybe I will talk about it later on. Understand some people have a bit of challenges joining, but hopefully everybody is able to join. I will once we finish this, I will sort of quickly summarize this morning's session, what we talked about, just in case for those that have missed the beginning. Okay, frat scale, yep. Okay. Okay. Assess patient home. That's Chibuze. I think that's one of the so environment basically. Medications, yes. So that's different aspects. Cognitive and behavioral assessment. So yes, behavior. We talked about behavior earlier. Fear of fall itself. Yes. Fear of fall. Yep. Okay. Thank you. These are brilliant suggestions. So is a question I put why and how. So why and how? Why are we doing this, and then how are we going to do it? So the first one is false history. Remember we talked about false and false history. False history, if we're looking at using our SOAP note, so looking at the subjective assessment, when you are doing your subjective component, you want to establish a picture of the part of how the false itself. Okay, talking about the frequency, the circumstances where it happens, the injuries as a result of fall. So you want to paint a picture of the false history. The time of the day. Earlier on, I still thank you, Francisca. Francisca mentioned patient for the lineage part took light, and so you look at maybe this person might have difficulty in dark situation. What sort of activity are they doing? Because past falls are the strongest predictor of future falls. And understanding the patterns at which these falls happened will help us modify their risks, help us identify possible modifications. Okay, there are things that we can modify, and then that will just solve the problem, and there are things that we can modify. So false history, it's one of the main things it's used in fault. It's in fact that's the main bit for false assessment. The second part is thank you for those that have keep on putting those in the chat box. The second part is the gait, balance, and evaluation, more mobility. Gait, balance, and mobility. So if you're looking at the SOAP note of assessment, if I said false history will fall under the subjective component, where would my gait, balance, and mobility falls under? Anybody wants to help me?
Falls under objective.
Yeah, brilliant. So the gait, balance, and evaluation will fall under the objective. And with the gait, you are looking at walking pattern. You are looking at speed. Earlier on, we said speed. We'll look at that also detail. The speed at which the person is walking. their transition from sitting to standing. When they are walking, how stable they are, or when they are standing, how stable are they? Are they swaying back and forth? Impaired gait or unbalance are direct contributors to fall. Directly, they can contribute to fall. And that's why we use, the commonly used is the talk test that we use for assessing falls. The next bit is we look at vision and hearing checks. Now, whilst some of those things can go beyond us where we make referrals, but we ask those questions about vision and hearing. In vision, particularly as a physio, what I will be looking at is I will be looking at what they call depth perception. So by depth perception, I'm looking at, so when you're climbing the stairs, the length of the stairs, sometimes you can, although we also do it, but sometimes you have tendency to misjudge the height of the step and you can trip or you fall. Or when you're going out walking in the environment, there can be uneven surface and you can misjudge the height of the step. Sometimes it's a zero problem with the depth perception. And that can affect you. And simply, the simple things we tend to do is, I can get 2 pens of different color, similar, and then I will just stand in front of a patient. I will put one closer and one far. Okay, and I will ask the patient which one is closer to the person and which one is far away from the person. Now, if the person is able to tell me, most of us will be able to do, but there are patients who will tell you that they are all of the same height, whilst clearly one of the pen or one of my finger is closer to the patient. Now, a patient that will tell you this, then is the question that you know that they have problem with their depth perception. Okay, and you can mitigate this by either educating them or letting them know that they need to take things slowly because they can't judge the height of things, or you can refer them to the ophthalmology or opticians to review their vision. So depth perception. Another thing is the visual field, where we all know that how you assess it is you try to ask the person to fix their eyes right in front of an object. For example, me holding this pen, I can ask the patient to just keep looking straight ahead, and I'll ask them to look straight ahead without moving their eyes. And now I will try to take the pen away from the point of vision and then ask them to keep telling me when they can see it or not. And I keep moving it to the point where if the patient says they can see it, I tend to wriggle the pen and then and ask them, what am I doing with the pen? Because sometimes patients, not just to impress you, they will tell you, oh, they can see it while they can't. And then wriggle the pen just to give them an understanding. I ask them whether they can still see it. And if they said no, they can't see it, it tells you that they have a narrow field vision, and they have tendencies of bumping into things, so they need to be aware of that, or injuring themselves because they can't see things, and so the vision is not supporting them to make appropriate adjustment as they walk around. So poor vision, hearing, it reduces, all of them have tendencies to reduce our environmental awareness and the reaction time, thereby increasing the falls risks. People mention about medication. I'm not a medication review. Sometimes it's just the medication the person is on. I know we are caught on, sometimes it's just the medication and it can increase the person's risk of fall. So by just reviewing the medication, then you will find out that it is likely, highly likely that that can be taken care of. Especially psychoactive. Sometimes the cognitive or psychological status. We talked about memory, attention, and the psychological factors here is the fear of falling. So people talk about fear of falling in the chat box a lot. I think people avoidance skill, fear of falling. So it's the psychological factors. Somebody, especially the elderly that have fallen, they will be so afraid that the fear of falling will increase their risk of fall. You can see the patients for them to walk, it's a problem. And if they're walking, they are so fixated. and they can put themselves at risk, and you as well, because sometimes they will grab you when they are falling as well. It affects their judgment and safety awareness. And because of fear of falling, it can reduce their activity and increases their deconditioning. Okay, it can lead to reduced activity and increased physical deconditioning, because I have fallen. The best way to avoid falling is to just lie on bed. Or I have fallen. The best way to avoid falling is just not to walk around. And that's not good. We all know that that's not good, because that will push them in that cycle of then their functioning will deteriorate. Is finding a way of trying to encourage, trying to support them. And environmental hazards, we have great examples here. The lightning. So all those things that you guys have talked, the lightning, because it affects vision, the floor surfaces, the stairs, the clutter, the bathroom safety, the accessibility, all of them are home/environmental assessment. All are home/environmental assessment. And they are important because most of the times it's not in the hospitals or in your clinic the patient falls. They falls in the home, at home, and possibly also in the community outside when they are walking. Excuse me. So modifying those environments can significantly reduce the risks. And I think also somebody mentioned footwear, footwear or foot health. Yeah, coordination can also be assessed. Thank you. Yes, coordination, absolutely yes. Coordination can also be assessed. So foot health and inappropriate footwear can impair their balance. They might have good balance and can impair their balance. And then we talked about the cardiovascular functioning, orthostatic hypertension, dizziness, can make somebody to just fall, really. So if you are falling, so the multifactorial assessment, sometimes a part of our physio is just for us to be aware of all the things that could be affect fall, and we make the appropriate referral to the other healthcare professionals. So just a quick, the strongest predictor of falls, just a summary of that bit, just to highlight, the strongest predictor of falls is falls history. So what it means is that once we establish that history of falls have a picture, it gives us a picture of, they are one of the main assessment that will tell us whether the person will fall next time or not. Followed by the assessment of physical functioning. So the second predictor of falls, second strongest predictor of fall is physical functioning. And by physical functioning, it talks about the coordination that somebody mentioned, the balance, the gait, all of it forms part of the physical functioning. But I will ask, and please unmute yourself or put it on the chat box. What is the recommendation for falls assessment? What is recommended for falls assessment? I think I've mentioned it earlier on. What is the recommendation for falls assessment? What is recommended? Is it that we should use the falls history, or what is recommended? Anybody wants to? From the last PowerPoint, what do you think is the recommended what is the recommendation for falls assessment? Okay, use the falls history. Thank you, Chioma. Anybody has any different view, or what is the recommendation? Follow NICE guideline. Okay, but Chibuze, what does the NICE guideline say? So that's what I'm asking. What is the recommendation? Or based on the PowerPoint that I've mentioned, what is the recommendation, Chibuze? Or anybody? Identified risk factors. Okay, thank you, Mohammed. Outcome measures, Yunusa. Okay. Thank you. What is the recommendation? Is there any evaluation of gait? Can we summarize? Anybody wants to summarize it in a single word? So let me, maybe I'll reframe it. What is the recommendation for assessment? Can anybody summarize it in not a single word, maybe 2 or 3 words? Age, okay, 2 or 3 words. Okay, age. Okay, what I want to raise awareness is and mention is all what you've said is true, but the recommendation is, which we talked about, is multifactorial assessments. Everything, yes, make use of. So the recommendation is, it's not in my PowerPoint here. I mentioned about the strongest single predictor of falls is falls history. Whilst it is the strongest predictor of falls, the recommendation is not just to use falls history for falls risk assessment simply because it's the strongest predictor. Neither is it to just use the second physical functioning. So the physical functioning is when you're doing your reasoning, you use your outcome measures to assess the patient in that. Now, the recommendation is to combine everything all together. Thank you, Sunusi. Is to combine everything all together so that it will give you a holistic picture of the person's health. Okay, so taking into account your falls history, taking into account your physical conditioning, reviewing the medication, footwear, everything we talked about all together. Outcome measure, we talked about outcome measures for a lot, so I will also talk specifically about them, but there are lots of them. There are lots of them, outcome measures, and I will share this on the chat, and please, by all means, you can put it on the WhatsApp group. Regarding outcome measures, one site I find extremely useful and helpful and evidence-based is rehab measures. Some of you may know or may not know. So it gives you a summary of, so I've put it in the chat box. You can go to this site and have a very good summary of outcome measures. So outcome measures is not only about just using a tool, it's about finding its relevance to use it in your clinic. Why are you using it? What does the evidence says in using it? How to use it appropriately? So this site will help you. If you're looking for an outcome measure, you can go in there and see those ones that are validated and out there in the public. You can find it, hopefully most of them, especially physio related, on this side. Although we know that it's not necessarily we have to always use outcome measures. You can use functional assessment. It's just to have a baseline and post baseline. But the outcome measure is a standardized tool that has proven to record the changes over time. So that's why we are highly encouraged to use it. So for falls, there are 3, well, a lot of them exist, but there are 3 main outcome measures that that are recommended, or that I would say we should always consider. One is the talk test, or the time up and go test. Just a quick one, just so that I will not be assuming. How many people? So the second one, and I will talk about, is the back balance skills. The third one is the functional reach test. Okay. So in the chat box, if I want as many people as possible, if or not possibly all of you, those that have used all the 3 before, or are aware of all the 3 before in their clinic, not necessarily for falls, but just generally in your clinic, you should put the number 3 in the chat box. Those that are used, or maybe those, so if you use the 3, can you put all the 3, just put talk, BBS, and FRT? If you used 2, just put the number 2, put the 2 in the chat box. TUC and TUG and BB. If you use only one, then you just only mention one, or if you have not used one, that's fine. You can leave it blank, so that I will know how much detail we can go in. Okay. Okay. Brilliant. I think most people have used all three. Well, so far the people that responded. Okay, so three. Okay. Okay, three. Okay. 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 So others have used one. Okay. Three. Okay. Okay. So I guess that makes my work super easy. Although not every okay one. Okay. Or maybe not. Okay. True. Okay. Talk on Friday. Okay. Thank you. Okay. So maybe I will, those that have used three, you're going to help me run through this slide. So let's start with time up and go test. Can I have a volunteer for those that have used three to talk us through how they have applied the time up and go test in their clinic, and why did they use it? What are they looking for? What type of patient they use it for? And what sort of outcome interpretation? So that's what I mean they're looking for. So anybody wants to go first? Those that have used the three outcome measures. Any volunteer wants to talk us through?
Good morning, everybody.
Yeah, good morning, Chioma.
So for the talk test,
Yeah.
you put a seat at one end and measure 3 meters from that chair to maybe over or to one end, another end, 3 meters. Then you ask the patient to, as with your timer, when you say go, you should stand up from the chair and move to that point and come back to the chair. So you calculate how many seconds it took the patient to get back to the seat and sit down. Thank you.
Okay. I don't know. You can answer or I can leave it for that one. So why the talk test, when you use in your clinic, what are you trying to assess?
The gait speed and probably the balance.
Okay. And what is there a number you're looking for, or you just looking at it generally? Is there a cutoff mark you're looking for, or you just looking at it?
Yeah, there's an average seconds to take them to get there. Like I think between 7 and I don't have the numbers. 12 seconds.
That's fine.
Yes,
sir. That's fine. And for your patient, just the last one, what sort of condition is it that you're looking out for, the person that you apply this talk test for?
The person is 92 years.
Oh, okay.
So they're just doing, when we have such age or elderly people, we just do it generally to be sure everything is fine.
Wow, that's good. Which setting is that? That's good.
It's a private clinic in Lagos.
Oh, okay. Yeah, private clinics. Okay.
And it is also used among amputees to assess either balance, the gait speeds, and fall risks, most especially when they are given prosthetic limbs.
Okay.
So it's part of the assessments.
Have you used it? Okay. You use it in your clinic?
Yes.
Okay. Yeah. Thank you. And do you remember the interpretation that you're looking out for? You remember, Suleiman? So so when you look at them after they do it, what does it tell you? You remember what you're looking out for? Okay, thank you. So talk test. Absolutely, yes. I think Chioma and Suleiman, they've mentioned it.
Okay, you are
yes.
looking out to see if the person is have high risk of fall.
Okay, good. If the person is have high risk of falls. And there are things that they will look out for. So Chioma have explained the process and procedure, and you can find information online out there. I'm not going to spend much time on it. But it's actually a good outcome measures to use to screen for high risk of falls. Example, the private clinic in Lagos. I think it's a good practice to screen elderly, especially at that age, using those outcome measures. There are a lot of things to look out, but mobility, balance, functional movement generally, because when somebody's sitting to standing, that's transition. Okay, that's transfer from sitting to standing. That's functional movement. So you're looking at that transition, functional movement, sitting to standing. Okay, but also you're looking at somebody is walking. That's mobility. You are looking at walking. You're seeing the quality of their walking, are they swaying, and then the balance, because there is that dynamic as well as static balance. When they stand up, they need to balance themselves and walk. So it gives you a lot of information, the outcome measures, and it is being validated. So you can look at the sites that I've put in. You can look at the validation population you can use. That doesn't mean you cannot apply it to your own context. That is where you will. Thank you, Suleiman. That is where you will see. So that's where the evidence comes, which we'll talk about it later in the afternoon. The fact that an outcome measure has been validated in a specific patient population, while that is the recommendation, you as a clinician, you can make a judgment for your patient on whether to apply it on the other context or not. So for the talk test, it's a risk of falls, but there are different way of categorizing it. Good. Yes, thank you. Okay, so maybe your numbers, now the numbers varies, but I put my numbers, it's maybe slightly varied from yours, but the numbers varies, Suleiman. Anything less than 12 seconds is considered, so the longer you take to walk the distance, the more risks you are. We talked about gait speed earlier on. But also, it's not only the numbers, it's the observation of the clinician in the quality and things like that. Anything between 12 to 15 seconds is moderate. Anything more than 15 seconds is high risk, okay? But I understand, especially if you are talking about amputee, for example, maybe you can have modifications. If you look at patient situation, you can have modification. There is nothing wrong with it. You can look at it in your context. Thank you. Let's move to the next one, back balance scale. I know there are a couple of people that have used back balance scales before. Anybody wants to, the same justice that Chioma and Suleiman have done for us, anybody wants to do the same justice for us? Ooh, that's a good score, 92, 7 seconds. Wow, that's good health. Thank you for that. So anybody wants to talk us through about back balance scale? So in your clinic, why do you use it for? What are you looking for? What does the measure, what does it assess, and any interpretation of it? Back balance scale. Amongst anybody any volunteer, people that mentioned about that they've used 3. Somebody different this time around. Somebody different this time around. Somebody different. Looking out for volunteers, please. Don't leave me. Yes, carry on.
Back balance scale, as the name implies, is used in assessment of balance and also for risks among individuals that have either neurological or musculoskeletal conditions. And it consists of 14 items. Which evaluate various aspects such as sitting and standing, transfers, reaching and leaning, turning, and then standing on one leg. So while using back balance scale, there are certain things you might need, like chairs, armless chair, and then the chairs with the armrest, and so on.
Okay.
Yeah, it
And
assesses balance and fall risks.
okay, but can we go back a bit? So when you said it assesses balance and fall risk, so let's talk about the balance. Balance contributor of fall. So when you talk about balance, is there any part do you want to expand, or anybody within the conversation wants to expand by when you say balance? What do you mean by balance? So is there any particular type of balance that it assesses? So balance is a broad, big term. Anything in detail that, yeah.
It assesses dynamic balance.
Okay, so Abdul talk about static. You said dynamic. So there are two ideas. So Suleiman, you said static, dynamic. Abdul says static. So which one is which? Is it one or the other or the both?
Well, it's been a while I used back balance scale, but
no, that's fine. It's just to just generate. Yeah, carry on.
Yeah, but from my understanding, dynamic and that of static balance usually is assessed with patients standing erect at the beginning with eyes open, arms by the side, and then you observe whether the patient's swaying whether side to side or forward and backward while paying attention, and then progress to eyes closed. All this is used in assessing static, but if activity is included in assessment of balance, it's usually dynamic balance that you are assessing. And in back balance scale, most of the items are assessing balance with activity.
Okay, but is there any component that assess balance without activity?
They are the first aspect.
Okay.
So it combines both.
Okay, that's why we are okay. Thank you for arriving at that. So I guess so. Thank you. I think that's a well reasoning. Thank you, Suleiman. That I like the line of thought. And I think people also in the chat box have been putting information. They mentioned about both. It assesses both. Janada and Ahmad mentioned about it assesses both. So yes, it assesses both static and dynamic, and absolutely Suleiman have laid the thinking and reasoning behind it. The static balance is where you are stationary. The dynamic balance is when there are activities involved. So the back balance scale starts from the static balance and move towards to the dynamic aspect. And because it's challenging, so it's progressive in nature. Okay, it's progressive in nature. When you start from the basics, and then if you've been able to achieve this, you move to the next. If you'll be able to achieve this, it needs to the next, up to the challenging aspect. I'm not going to talk about balance because balance can take us a whole day to talk about balance, because even in the dynamic balance, there are also different components, but that's not what we're looking at, okay, today. But if you are interested, you can go ahead and explore that. So the dynamic balance, we also have different subcategories. So that's the back balance, static and dynamic. They are all both important in falls risk assessment or falls. Our patients are walking, that's dynamic balance. When you are walking, they have to maintain themselves. They have to be able to balance themselves whilst walking, not only in the dynamic state. Now, coming back to still those people that have mentioned about their ability, they've assessed both. Do you remember the scoring of it? What sort of numbers we're looking at? Anybody? Scoring of it, the scoring of the back balance. The scoring of it. Anybody remember the scoring of it? Or the interpretation of it? Any volunteers?
I think someone has put it in the chat.
Okay. Oh, yes. Okay. So that's maybe let's explore that a bit. So the person put 0 to 4, total of 46. So I guess the 0 to 4. Yeah. Carry on, Suleiman.
No, the scoring is each item, each of the 14 items is scored from 0 to 4.
Yeah.
0 meaning unable to perform the task.
Yeah.
Then 1 to 3 performs the task with either assistance or modification.
Yeah.
And then the 4 score means he performs it independently and then safely.
Yeah.
So the maximum total score is usually 56. And the interpretation is that a person scoring 56 has excellent balance.
Yeah.
Well, though there's difference in literature, Sha.
Okay. What do you mean
A
by that?
person scoring between 0 to 20 means poor balance. That's high fall risks. That's the interpretation. Then 21 to 40 is fair balance.
Okay.
With moderate fall risks. And then 41 to 55 is good balance. That's low fall risks. When the 56 is the excellent balance.
Okay. So when you say there are different, there is literature, is it with the scoring cutoff marks that there is debate in the literature or something else?
No, it's like, you know, sometimes the, what is it called? The outcome measures, the interpretation. It's like some clinics, when you go there, when you give them the scoring you have with the scale, they'll say, no, this is not what they were taught, you know, even though without evidence, they will argue. So that was why I said that.
Okay. So, yeah, thank you so much, Leman. So, agreed. Absolutely. The back balance scale is an outcome measure for dynamic and static balance. It starts from the static, goes to the dynamic. These are two important components of balance that, as clinicians, you should access when you're seeing a patient with balance issues. But like I said, today is not balance rehabilitation. Maybe we'll talk about balance rehabilitation sometimes on a different things. It's one of the areas I'm more interested in. But also dynamic balance, there are different components of dynamic balance. Well laid out, 0 to 4, 4 being the maximum, 56. There are scoring for it, 46, 41 to 56 independent mobility. Sometimes there is a cutoff point of 44. Now, yes, there may be debate on the literature, but I think this is one of the objective markers that we use. Here certainly is back balance as a physio. I don't think you will miss that out if you are working in the community. You should know back balance in the fingertips here. And if you're going to work as a physio, especially in the community or in areas where you see persons with balance challenges. Time up and go test, yes. And another advantage of the back balance for those that are looking at it, I will recommend is it has the same activity that you will use for assessment. You can use it for treatments. Easy. You convert the challenges that the patient cannot be able to attend into treatment by modifying and lowering it in a safe environment to the point where they can be able to do it. If it is sit to stand without support, you can increase the chair height and then allow them to do sit to stand till when they can do it. If they can stand with the legs closed and everything, you modify it and they can do it. And one of the challenge earlier on today, I mentioned that we will have a challenge today. And my plan is we will try to have this challenge before we go for the lunch break. And one of the challenge might be part of the back balance bit. And whoever is the first person to win the challenge will have their full refund of the CPD fees. I will refund them their money for CPD. So just to mention, which we talked about, the back balance scheme. Yeah, thank you. So let's move to the next bit, the functional reach test. The functional reach test is pretty much the same. You can use it to assess balance. This also is interesting, false risks as well as balance, because you can go and read about the implementation and things like that. As the picture shows, it's just stretching out and then finding you can draw a 25 centimeter less than an A4 paper is, I think, is 30 or so. So just 25 centimeter off an A4 paper. And from that point, you measure the 25 and then the person try to reach as far as possible. It challenges your balance because it takes you away from the base of support. Okay, it takes you away outside your base of support, and it's about your ability to be stable with displacement as well as to recover back to your base of support. Okay, which is an important component of balance. So it assesses the stability, the functional reach test. It assesses your stability and balance during the forward reach. And the scoring is on the screen. Low risk, and if you can be able to do the full 25 centimeter, brilliant. But if not, then it categorizes your risks. The next bit is so that's the summary. Balance. Assessment generally. We talked about assessment. Assessment is multifactorial, looking at different components. Start looking at vision, physical functioning, outcome measures, medication review, footwear, all those bits. Then the next part is the intervention. I'm coming back to the nice guideline flow chart that I shared early. For those that are joining us, I shared it in the chat box, and I believe that has been circulated, although I didn't confirm in the WhatsApp group. So false intervention. So the recommendation, earlier on we talked about, coming back to the picture, earlier on we talked about there are 2 points at which patients expectedly, based on the flow chart, that will come in contact. One is that they have fallen and they come to us, okay? Or maybe they are worried about falling. The second one is the incidental findings, or whereby we do a normal health review and then we come across patients who have problems with falls, and then we review them. I think Chioma gave us an example. They do a normal routine review for individuals who are at that certain age, which is good practice. So whichever point at which they come, if we are taking at the point where they have a fall, if you go all the way, we've already discussed the first 3 stages. So when a person is at a high risk of falls, so high risk of falls is at my right-hand side. For those that are here, probably will be able to know about those that are joining. So it at my right-hand side. One is recommended that we do multifactorial falls risk assessment, but also it is recommended we have a individualized, tailored intervention for those patients. What does it look like? That's another areas we're going to be looking at. Okay, and then you follow up that. We follow up that in the next 30 to 60 minutes. I think there is a very good, important question that was, well, not question, comment, and I'll come back to that because I absolutely agree. Then the next part is the if somebody is at the intermediate risk or low risk, we tailored the exercise on balance, gait, and strength. And that's where the physio comes in. They will refer you, and we educate patients on falls prevention. So both intermediate and high risk, it's important for tailored intervention as well as possibly education as well. Sorry. And then the low risks, we can educate the patient on false risks and advise them actively on physical activity and exercises, which we talked about earlier. We talked about our role in physical activity or exercise. So the question is, what do you include or should include in the intervention? So when looking at the intervention, and you can put a bit of details in it. What do you include or should include in the intervention? Just like we did for assessment, I want us to make a list. But before we go on making a list, there was a comment on the chat box about Abdul Rahman. I absolutely agree with you. You said the challenge is back balance skill is timing. Now, before I give you my answer and how I applied it, and I think for me, I find a way, maybe not. Just I will put it back to the audience. For those that are use it, or what do you think? So the challenge, let's say we have a challenge of timing or not. How do you go around it? How do you go around if those that have implemented bank balance skills in their clinic? How do you go around the challenge of timing? Because it's 56 questionnaire. That is a lot of questionnaire. Four responses that you have to go. So it's 56 times 4. That's in excess of 200. In here in UK, I guess you are time bound on how much you can see patients. So you need to finish everything and continue and move on. So those that have used it in Nigeria, can you please advise us? How do you go around the timing of challenge in back balance scale? Anybody wants to give us share their, okay, there is a modify form, okay? Isama talks about there is a modify form. But even with the modify, okay, that's good. So uses the modify form, okay? Anybody else wants to tell us more about how do they go around it? Those that use it, how do you find it? Do you find it challenges? How do you go about it or not? Yes, Yunusa Mohammed Usman.
Yes, sir.
Yeah.
Like actually, we used to start with the highest number, that is score of 4.
Okay.
Because if the patient can perform the 4, so no need to assess the rest. He can definitely do 3, 2, and 1. Just we go like that.
Yep.
But unless if he can't do it, so we have to follow all the four tests that carry out. That's how mostly we minimize the timing.
I agree with you, Yunusa. Thank you. And that's one of the things I actually do. Yes, absolutely, yes. Anybody has anything they want to add? So yes, let's crack on. One of the ways to just thank you, Abdurrahman, for raising it. But one of the ways also, which maybe you probably also have find ways to do it, is what UNISA says. So there are 5 questions from 0 to 4. So instead of you going from the 0 and going all the way, you just go to the highest score. And then if they can do, you move to the next bit. Another way is you skip, because somebody who is practically on their feet, you don't have to worry about sit to stand. If you think that they can be able to do that, so you skip and you start from the challenging aspect, and then you progress going forward to the point where they can't do it, and then you take your score. That's another way to look at it. And really, outcome measures are tools in our hands that are meant to help us. Okay, we should not. We need to consider the practicalities of it, and that's one of the research challenges of having a beautifully crafted piece of evidence, and then it's of no relevance or utility, which we will look at in the afternoon in clinical application. So sometimes you can decide even to just skip it and then start from the highest bit. Okay. And then you take it off from there. I think that's one of the challenge. Maybe less likely. Sometimes people start and stop and then continue at a later stage. You don't have to finish everything. But I agree with you. Now let's come back to my slides. Let's make a list. In terms of intervention, based on what we said, we will assess. Based on what we said is the problem. What should we include, or do you include in your intervention in falls? You can put it in the chat box, or you can unmute yourself. Any contributors, volunteers? This is the most exciting part. So I will expect some people to be typing, flying with chatting, typing in the chat box. What should we include or you include?
All right. Good morning, everyone.
Yeah, it's still morning, Chibuze.
Can I contribute?
Yes.
All right. In management of fall, you normally involve a multidisciplinary team. It's not something you manage alone. So it's something you involve the podiatrist, you involve the ophthalmologist, because the patient presents with a lot of things, like looking at the NICE guideline.
Yeah.
Or the multifactorial fall risk assessment, a whole lot of things could lead or predispose someone to fall. So it's not something you manage alone. It's something you involve all the other team, all the MDT teams to join you in the management of the condition. So you can also involve the occupational therapist who go home to ensure that the home is covered, modifications that needs to be done, grab rails, maybe slippery, uneven floor, a whole lot of things. So it's a disciplinary team approach. That's the best form of management. Thank you.
Thank you so much, Chibuze. But if you will stay with me now, that doesn't mean you must answer my bit, but I just want to explore your line of thought a bit more. I agree with you. Absolutely. It's multidisciplinary. That is the first approach. You talk about the podiatric because earlier on we talked about footwear affects falls. So it needs to look at footwear. You talked about occupational or health or what occupational therapies. We talked about home environment. You talked about vision. We talked about ophthalmologists. That are brilliant. So that's the first thing. Multifactorial bit. But apart from multifactorial bit, so that one is multifactorial bit. Is there, looking at it specifically, let's say for physio, what are those things that you think we should look at? Okay, somebody have started putting a chat box, but if you want to talk about any word like the same thing you discussed about your multifactorial bit, anything we can look at as a physio, Chibuze?
All right, as a physiotherapist, especially managing a fall risk or a patient with a fall, looking at the NICE guideline, what they mention about the age factor. Okay. Especially once a patient reach 60 years and above, the person they are normally predisposed to fall because of the weakness of the loss of muscle mass due to age-related factor. Okay. So I think that we should also be looking at that one, looking at how to train this patient to ensure that this patient, the lower limb are stronger, carry out a whole lot of assessments to ascertain the cause of the fall and how best to manage that.
Okay. Thank you so much. Yeah. But just to mention, 60 is not old person in UK. So don't tell somebody 60 that is still good to go 60. But anyway, that's just saying, but 60 is still good to go. Especially if they are well looked after. 60 people, they are still bouncing.
65 years, looking at the NICE guideline, it says 5 years and above. That is when there is normally loss of muscle mass, especially in the lower limb, that predisposes someone to fall. Sorry about that. It's 65, not 60.
No, that's fine.
Thank you.
Yes, thank you. So I think there are people, Abdul Shakur and Alheri, and they've been putting ideas which are great. So as a physio, what we're looking at is there are different things, what they call multi-component. So that's what I want us to look at. So one, there is the multifactorial or multidisciplinary, where you look at different healthcare professionals. And then there is another part where you looked at multifactorial or multi-component, whereby as a physio, you look at different aspects. Okay. Earlier on, we talked about gait. We talked about so gait can affect falls. How? Let's say lack of flexibility of at the Achilles tendon or tibialis anterior. it affects the person's ability to react to balance when they trip. So you can look at your flexibility exercises. We talked about balance. We looked at outcome measures. You can work on their balance. So different components that contributes to balance is what you should look at. Gait, balance, functional ability or transfers, coordination. And if we look at back to my flow chart, we said the person with the high risk of falls, if you go all the way down, they mentioned about individualized tailored intervention. And the reason is because once you identify those things that contributed their balance, generally, yes, you will refer to the multifactorial different disciplinary people. But as a physio, you need to come up with exercise. Exercise like that, like just a sheet of paper, oh, exercise is good, but you need to be specific. Are you targeting the balance? That is the problem. Or are you targeting the coordination? That is the problem. Or are you targeting the strength? That is the problem. So you need to probably identify what is the problem, and then your intervention should address the problem. By merely just asking the person to just do some activity or going for general physical activity is great, it's excellent, and everybody should be doing it. But for somebody with high risk of falls, you need to be specific on the factors that predisposes them to falls, address them, and where possible, or come up with compensatory strategies. So also for somebody with medium, moderate risk of falls, and also includes education for that bit. So yes, thank you so much for the contribution. One we talked about is the multifactorial. The second bit is the multi-component physio-specific multifactorial, looking at all the MDT team. There are a lot of successes in terms of intervention wise, a lot of research out there on falls intervention wise. One of the main one is the Otago exercise program. If there is anything, one of the things that you can take away from today is, I know some of you maybe have been using it, but Otago exercise program is one of the good things that you can go and pick and use in your clinic, where they are looking at basically strength and balance. Okay, you can modify it, but Otago exercise program is one of the things you can look at, and you can find that out in the information online, or maybe I can make a list at the end and I can share that with the whole group of all the things we've been mentioning. One, the Otago, and two, possibly the outcome measure, but you can find those online. So, ideas to impacts. Earlier on, for those that are joining us, or maybe before we do the, yeah, I will talk about this later. For those that are joining us, when I started today, one of the things I said is I will refund whoever that has been able to do the challenge. I will refund their fees by 100, the full 3,500 CPD fees. Okay, so the challenge is, we are talking about balance. One of the things is balance, but we are talking about false risks. One of the things is balance assessment, balance intervention. There is what we call dual taxing exercise or balance exercises, whereby the person uses two different things at the same times. One is you are challenging your balance system as well as your cognitive system, and to a certain extent your somatosensory system. So three systems that contributes to balance. The somatosensory system, talking about your muscles and information you received. You talk about your memory, your cognition, and the vestibular rather. Yeah. So if what I need is the evidence that the person, whoever is going to do it, and I will encourage, we are all going to do it. Yeah, we are all going to do it. We are almost getting to lunchtime. What I want us to is we're going to stand up. We stand on one leg. Okay, we stand on one leg. You close your eyes. Okay, so whilst you're standing, you close your eyes. And then once you're closing your eyes, you count from 100 in threes backwards. How do you do that? You count from, let's say, 100. The next 100 is 97. The next bit is 94. The next bit is 91. So you do that as quickly as you can. Okay. So you count from 100 backward and you do that as quickly as you can. So that is the challenge that I have for us today. And whoever that is able to do that quickly, I'm aware of the technicalities. If to say it's a face-to-face training, it will be much easier for me. But since it's online, so there are two ways I will like to approach this. One is we do it online, but again, if I'm not able to find a winner, I will give from now till probably tomorrow, 24. Whoever has you can record the video and then forward it to the organizers, the CSP organizers. Whoever has the fastest time, they do it and do it accurately, and the people that have sent their video quicker, they are the ones that will sort of get their full refund. But now I want us to try this, all of us, okay, as much as we can. Okay. Can we all be on our feet? Let's have a practice session. Yeah. I don't think I'm able to do it anyway, but let's have a go. So let's have a practice session. I know we've been sitting for a long time. So let's have a practice session. Okay, and we all be on our feet. Okay, that's good. So I guess we have all on our feet. We'll have a practice session, and then it will be, I will now turn it over to whoever will first of all start with the video here. Okay. While standing on our feet, can you stand on one leg? I'm actually standing on one leg. I guess you want to see the evidence, right? Okay, the floor type have not been discussed. I will come back to you, Jamilu. We'll talk about more when you said about the floor type. So let's stand on one leg. Okay, standing on one leg. Okay. Make sure you are, just to advise, make sure that if you have problems with your balance, please don't close your eyes. Don't stand on one leg. If you have any injuries, it's not easy, Mubarak. That's true. Stand on one leg. Can you stand on one leg? Okay. Please don't do this if you have problem with your balance. If you are swaying, if you are having problem even by standing on one leg, please don't close your eyes. But if you don't have any problems, the next thing I want you is close your eyes. Okay. Close your eyes, and now you start counting from 100. Okay. From 100. 97, 93. Yep. Okay. Okay. I can see we have a couple of I think we have Chioma in the call. So what I want to do now is everybody can keep practicing, but I'm going to have probably give 2 or 3 people who will, let's see if anybody can be able to meet up with that 100. Okay. So who wants to take let's start from here. Let's see if we can. I think we still have a bit of time. I can see Chioma is already cracking on, but there is no evidence that we will know wound fatigue of the stance leg affects the overall result. We can do it with support now. Okay, so I can see Yunus is doing it. Can we start? Let's have a setup. So that's a good research question. So can we have a volunteer who want to start for us? Is it Chioma, Yunus? Do you want to unmute yourself and count for us? Let's see who will reach to 100. Yep.
Small counts, so it's difficult to count.
Okay,
and stay
that's
there.
fine. Whoever I need 3 people. So Chioma, Yunus, who wants to join the train again? And I will, yeah, join. Whoever wants to join, join. Yep.
I can join.
Yes, join. Yep. Okay, I will. When you are ready, are you all ready?
Yes.
Yes, can we?
Okay. Wait first. Is Abdul Baki here? Is anybody of the NSP Gombe State chapter? Any officials of the Gombe State chapter here? Can you please take note of the winner? We want to get the winner, and then whoever is the winner, please will. Okay, so we are going to start now. Are you ready?
Yes.
Yes.
Ready, steady. Okay, go.
197, 94, 91, 88, 85, 87, 9, 70, 87, 4, 1, 58, 5, 2, 49, 40, 43, 30, 27, 40, 18, 12, 9, 8, 3, 1. I'm done.
Well done. I can see Yunusa is still on it. Well done, Chioma. Well done, Yunusa.
I'm done.
Well done, Esther. I think I can see that you're trying to follow. When the Unwachuku Nkechi, yeah. Thank you. So some people are saying it's easy, it's difficult. I guess we can start from there. Is it difficult or easy?
It's not that difficult.
Very hard.
It's very easy.
Not that difficult.
It's very easy.
Okay, I hear you. If your eyes are open. I guess that's another challenge for us. We can try to use that and see if we can improve on ourselves, on our balance. It's not easy. Absolutely not.
It's not.
No, it's not.
I'm aging now. We're also children. 56 to 60.
Are you serious? Congratulations. Well done, ma.
56.
Yeah, the eyes component. Okay. Well, we just to talk about this activity we've done before I move on to my next slide. In terms of how it affects your balance and everything. So first of all is when you're standing, standing on 2 legs, you have a very good base of support and you can be able to support yourself. So base of support is important contributor to balance and as well as falls. Once you challenge the base of support in whatever shape or form, it's become difficult on your musculoskeletal system, everything, but particularly your musculoskeletal system has to work harder to balance that challenge. Okay, so standing on one leg, you are challenging the musculoskeletal system or the somatosensory system of balance. That's one. The second one is closing eyes. So vision gives you information, sensory information to give you sensory information about your awareness, but also contributes to your balance because it gives information to your muscles and space and everything. So when you close your eyes, now you are only relying on your vestibular system, cognitive system as well, to maintain you and some proprioception in your legs to get your balance. So it's difficult for you is two things. But when you start counting backwards, you are taking away your cognition. Now, imagine those elderly people. Cognition maybe is not one of the things we appreciate a lot. If they have problems with their cognition, that's how it will affect them. So immediately you started counting, you lose the concentration on your trying to balance yourself, your eyes is not there, and then you lose your balance. And that's how it affects them. And when you're doing your rehabilitation, and we talked about it earlier on, it's important you look at what contributes to their balance and work on it. Sometimes it's not only about our physical exercises, it's also about the cognitive loading, what we call cognitive loading. And we'll look at that in our research impact later on in the afternoon. It's about your cognitive loading, how you challenge them cognitively. Also, with the dual taxing, you don't maintain your balance in isolation. Earlier on, we talked about balance being static, being dynamic, dynamic being when you have an activity. Most of the times, the function we do requires dynamic balance. So that's why important when you add that cognitive loading, ability of a person to count backward or do other things while maintaining their balance, it's important in supporting them in function or in translation to function. So whenever you are working with your patient, it's important you think about how will they function in the society by adding that extra component of it. But thank you so much with regards to the challenge of the video. And I still maintain I can't see somebody who has completed the one leg stance, eyes closed, counting backwards in 100 as quickly as possible. I try to check the videos. I see some people trying to reach out for their hands on the wall. I see people, so it's difficult. But my offer still stands. If anybody can prove, either record themselves doing that within that bit, please email it to send it to organizers of the CSP 24 hours. So basically from now till tomorrow, if you can prove that and do that, whoever is the first person and the fastest person, you will receive the full refund of the fees of the CPAD for one person only. So talking about interventions, the NICE guideline is what we consider, but again, all of us, what we'll be looking at in the afternoon is how we can use the intervention. It doesn't have to be NICE guideline really, but there is strong evidence that exercise-based programs are most important component of preventing falls or falls prevention. So most of the falls prevention activities or falls prevention programs, we looked at Otago as an example, but most falls prevention program focuses on balance, strength, coordination, and functional tasks. So everything you can do for your client, for your patient, to make them improve their balance, strength, coordination, and functional tasks. And for balance, it's about what we do, for example, standing on one leg. And for those that probably have not used back balance scale, standing on one leg is one of the highest activity you will do on back balance scale. Is the 14th question you will do. And that is when I said you can use back balance scale and use it for your treatment. This is one of the things. So standing on one leg. And if standing on one leg is easy, you can add it with eyes closed. If eyes closed is easy, you can add it with counting backwards. But that is not part of back balance scale. And that maybe will take me to just a bit of side comment. With those outcome measures, and some of us may know as well, there is what we call ceiling effect as well as flooring effect. So they only detect changes within the parameters they were set on. While back balance scale is brilliant, there are other outcome measures. Some of our patients will not be able to do back balance scale. And that is why you need to find the appropriate outcome measures for your patient. And you find an outcome measures that have a lower, maybe because lower ceiling effect that is not as challenging as back balance scale. Or maybe there is, for athletes, for example, back balance scale is not used for healthy adult or athletes because it has a ceiling effect. It cannot detect any changes beyond that one leg stance. But today in the class, I asked you guys to stand on one leg, to close your eyes, and then to count backward, which is very difficult. It is not part of the back balance scale component. So it's possible for you to get 56 out of 56 in the back balance scale, and still your balance, of course, it depends on the high demand activity. We talked about environment. It's still not optimal depending on the activities you want to do. And then that's why different outcome measures will come into place. For example, high math. So, but the intervention is balance, strength, coordination, functional exercises. The other multi-component is the home hazards assessments. We talked about it. In Nigerian situation, but I guess we physios, we can also double as the occupational therapist. It doesn't, because we have the very limited availability of OTs. And then the medication review, drugs can affect person's balance. And that's why sometimes you can feel dizzy, you can fall, you lose your sense of orientation when you have certain drugs. Vision, where you see the ophthalmologists, opticians to remove cataract, vitamin D, and other psychological factors. Fear of falling, and I have a lot of experience on this. Fear of falling, patients' fear of falling, no matter whether they have a good strength, balance, coordination, simply because of fear of falling, patient can have a difficulty in them participating in their day-to-day activities. And they can also increases them having a falls again. Sometimes it's not the physical functioning, it's the fear of falling. So, intervention summary. We have multifactorial interventions and we have multi-component intervention. The multifactorial intervention is looking at all other MDT teams that I think is it Chibueze that mentioned earlier on. Well, the multi-component intervention is what our bread and butter as physios, that we're looking at balance, coordination, functional tasks, strength. Exercise, of course, is the obvious choice for balance prevention because impaired strength and balance, they are the greatest increased risks of falls. I think there is a bit of chat in the comment in the chat box. Yes, I agree with you, AAA1. Seniors cannot do that. My stand limb nearly collapsed. Please don't try to do that. Yeah, it will. So that we need to tone it. This is a high level because I believe most of us are hopefully fit and healthy. Seniors cannot do this type of exercises. All you need to do is look at very simple exercises. Otago exercise program have simple basic exercises for the seniors. It can be marching on the spot. It can be even single leg raises. It can be just walking sideways, backward and backward. It can be walking and counting. There are lots of examples. For the interest of times, maybe when we have time later in the day, around 4 or 5, I can revisit that in terms of, I can give ideas for the interventions for different categories. But for now, I will leave it at that. But yes, I agree. So to wrap up, what I want to say, and the key message is, we need to be systematic when you're doing the assessment. Falls, we looked at healthy aging. Healthy aging, we have the aging part, we have the healthy aging part. The healthy aging part, it's about investment in the future where you participate in physical activity exercise to maintain your functional reserve so that when it's being challenged, you can still recover. Patients at risk of falls or falls, what I would say is when we are assessing, we need to be systematic. Systematic means we look at right from the falls history all the way through to our objective assessment and paint a multifactorial picture of what is their challenge. Okay. And I've shared whatever it is, the flow chart, but again, in my other PowerPoint, there is that systematic way of doing it. In our intervention as well, we need to be targeted intervention and systematic. It is not enough for a patient to come to our clinic and all we say is exercise, exercise, exercise. And we give them every single exercise that comes to our mind. I think it's important we find exactly what is their problem and we find specific exercise in addition to general recommendations such as physical activity, specific exercise. So this is what we call the multi-component exercise that will help them. Is it balance they are struggling with? We talked about balance, dynamic and static. The fact that somebody is standing, that doesn't mean that they have a problem. They don't have a problem with balance. So we work on their balance, we work on their strength, we work on their coordination, we work on their functional tasks. Or it might be something beyond our control as physios. That's why the multifactorial intervention comes in. And we need to appreciate the role of other MDT team and refer them. Is it the vision that they need to look at? Or is it maybe some psychological factors that we need to reassure them and make sure that they are able to overcome their fear? And hopefully these are all the things that we'll look at. That is all I have for this morning. And I think we are bang on time. I will give the last 5 minutes because we are going to be flexibility also. Absolutely, yes. Flexibility. Flexibility is important. I agree with you. And I can talk about it more because, like I said, somebody with tight ankle movement will fall because they cannot be able to, whereas what we call ankle strategy, they cannot be able to compensate for any disturbance or perturbations because of lack of flexibility in their ankle. So yes, flexibility is important. So I will stop here. The idea is we'll go for we go for 1 hour break and we'll come back by 1:30. Please, let's be here by 1:30. I will start my session by 1:30 on the dot. But also before we go on break, I'm going to stay here. If you have questions or you want to add anything, I'm more than happy for us to, you can put it in the chat box or you can unmute yourself and any questions, I'm happy to answer it. But apart from that, if not, I will see you by 1:30 where we will look at research for impact. Thank you, Suleiman. Suleiman mentioned about the lot of cases of lack of flexibility, reduced pace of support. Yes, all these are different components of the balance bit, but that's good that there is that awareness. Thank you so much. I will see you by 1 o'clock, 1:30 rather. But I will be around. You can, I think that's the end of the morning session. See you all later a bit. Yeah. Yes, Yusuf, I believe that my understanding is that's why we are taking a break now. Today is Friday. Some are going for prayer. Yes, you can go for your prayer, Yusuf. The plan is hopefully by 1:30, everybody is done with the prayer, but I may be wrong, but that was my understanding, the conversation I had with the organizers, that hopefully by 1:30, okay, not exactly. Okay. So Okay. Suleiman, what time did okay, 2 p.m. That's a lot of time. So we should have break by what do you call it? By 1 o'clock then maybe. Oh. So I got my timing wrong because I thought my timing people have already left, Suleiman. So it's probably not gonna be possible to bring everybody back. I will see what I will speak with the organizers and see if we can delay it till 2 o'clock, because I would have continued till 1 and then break, but people have already left, so it's not probably feasible to continue, especially okay, some pray 1:30, 1:45. Okay, so maybe there was a misunderstanding of the timing. But thank you, Suleiman, for bringing it. I will need to communicate. I can't continue because we've already break for people. But I will communicate whether we will have a delayed start, and then we have a break in the afternoon. We can shorten the 30 minutes break we have later on. So we have a break around and we can shorten that around this 3:30. Maybe we can shorten that break. Can you let me know, Suleiman, what of the other prayer in the afternoon? What time is it roughly? So that when I'm having a conversation, I know exactly what we're looking at. Okay, maybe people are not here. Okay, yeah, break time. I think let's go for a break now. We can't continue, like I said. Okay, 3:30, 3:45. Okay, so we might make it 15 minutes then. Yeah. Okay. All right. I will communicate whatever on the WhatsApp. Okay, thank you. I think that's break time. See you guys later.